Hi, everyone. This is Kelly Friedlander. We'll be starting the webinar in just a few minutes. Good afternoon, everyone, and welcome to VIA Health's Lunch and Learn webinar on health versus safety and risk versus liability. We're really excited to bring you this Lunch and Learn webinar today. This webinar is being sponsored by the North Carolina Council on Developmental Disabilities and North Carolina Money Follows the Person project, a Medicaid project that assists Medicaid-eligible North Carolinians who live in inpatient facilities to move into their own homes and communities with supports. Our first presenter today is Jesse Smathers. He's a Special Populations Clinical Director at VIA Health, and he's also the Project Manager for the Supported Living Initiative. Jesse, I'll turn it over to you.
Good afternoon, everyone. Thank you for joining us today. Today we're going to try to address health versus safety, and risk versus liability. And my role in this presentation before Derek Dufresne speaks is to give some background in North Carolina about the history of supported living, the changes that have occurred in the state, and then set the stage for Derek's presentation. And we also plan to take several questions today, so please be ready to type in your questions so that we can have some dialogue about health versus safety and risk versus liability. Next slide, please. Has the slide changed, Kelly? It hasn't on my computer. I'm not seeing the slides now, Kelly, so, okay, hopefully we're on. There should be a slide with the map of the state present. Hopefully all of you are seeing that. I'm not in my connection, which was working earlier. But the purpose of this slide, if you were seeing it, is to demonstrate the different LME MCOs in North Carolina. Local Management Entity Managed Care Organization is what LME MCO stands for. And we are, all of us contract with the Division of Mental Health, Developmental Disability and Substance Abuse Services, and the Division of Medical Assistance through North Carolina to offer services through Medicaid for behavioral health and intellectual and developmental disabilities. What you're calling in for is primarily because you're interested in intellectual and developmental disabilities. All of these MCOs administer the North Carolina Innovations Waiver. The Innovations Waiver is our home and community-based services waiver that provides services to people in the community that would otherwise be living in institutional settings. The waiver is a slot-based program, and it's optional Medicaid services. And what that means is that the state legislature has to approve any funding that goes into this program. Currently, there are 12,488 slots for innovation statewide. That number changes on January 1st to 12,888 because the General Assembly in the session this summer allocated 400 additional slots for people that are on the Registry of Unmet Needs, which is the wait list for the waiver. In this map, you see that in North Carolina, there are 7 MCOs or local management entities. I'm sitting in Asheville, and that's the seat to VIA Health. VIA Health is mostly the western part of the state. We're 23 counties. There's also Cardinal Innovations Healthcare, Partners Behavioral Health Management, Alliance Behavioral Health Care Offices, and Sandhill Center, Trillium Health Resources, and East Point Office. These MCOs are all situated with the same mission that VIA has, which is to coordinate services for people with mental health, developmental disability, and substance use services that receive Medicaid funding. The mergers in these 7 MCOs are the result of 40 area programs that since 2001 have merged or started working together in some manner. There's also the possibility that additional mergers will come forth in the future. There's different partnerships between all of the MCOs. And if you haven't seen it, VIA recently announced with Alliance Behavioral Health Care and Trillium a partnership to coordinate services in a manner that where we're really focused on integrated health care. Next slide, please. To give some specific background about VIA Health in our area, because this is the point where we have the most influence, or the way the initiative is the most impactful, because we have the most control over the provider pieces that are occurring. VIA Health is the 23 westernmost counties, and we have a total of 1,676 waiver slots. That moves to 1,719 on January 1. And currently we have 18 people that are receiving supported living through the initiative. During a planning meeting we had last week, we were talking about when would supported living become the norm in the state, and there was some discussion about Simon Sinek and his idea about 17% being the tipping point. Once the population reached about 17%, we would be predominantly using supported living. That basically means that statewide, about 2,200 people would have to start using supported living for it to be the new norm. One thing we're learning within our initiative is that the fear of using supported living is very prevalent. Health and safety is often a reason given for not using supported living, and sometimes providers are confusing risk with liability for the organization. Next slide, please. If you were to have a jar full of flies, and the jar had been that way for a while, and the flies had been in the jar circling around for a long time, if you open the jar, most of the flies just continue to fly around in circles because that's what they know. Occasionally one will wander out, and then they realize, the others start to realize that they can come out. The tendency for flies to stay in the jar is labeled premature cognitive commitment, and that's an activity that we as humans do all the time. We're so fearful of change that we get trapped in the way that we're doing things where we don't see any new way of doing it. And we have to change that piece. We have to be one of those flies that's willing to wander off into the unknown before we can really make this initiative work. The reference to these flies I took out of a book written by Delio called Raymond's Room. And the book's a story about his experiences working with people in the support system or in the IDD field, and how we often don't pay enough attention to them and don't learn from the folks receiving services like we should. We continue to do things the same way over and over again. And if you've been in the field a long time, you know that that's mostly true, because we've been utilizing the same model of services really since about 1978, when you start talking about group homes and day supports programs and those kind of settings. Very few states have really made the shift towards just supported living options. Some have and others haven't. North Carolina made some real substantial steps towards supported living in the 90s due to lawsuits. And then following mental health reform, different funding streams were pulled from that, and the ability to push or to help people move into supported living settings was limited because of those changes. So making the effort to move forward with supported living now is something that we have to do, because it's becoming more and more clear that the services that we have are not sufficient to meet the need, because, as I've already mentioned, we have 12,888 waiver slots, and we have more people than that waiting on services through the waiver. Next slide, please. One of the barriers that we often experience when trying to work with folks to move into supported living is people tending to see the person with disabilities not seeing their strengths. We tend to start from a place of disability. To illustrate that, I've put a picture of David versus Goliath here. I read a book a few years ago by Malcolm Gladwell, and it's called David versus Goliath, and it's the story about underdogs and overcoming great obstacles. And he opens that book with the story about David and Goliath from a different vantage point than most of us have heard in Western culture. During David and Goliath's day, the two armies, the Palestinian army and the army of Israel, were on opposite sides of a valley, and they were going to fight over this valley, and neither army wanted to go down into the valley and then ascend the slope to attack the other army. Because of this, and this was pretty common in ancient warfare, the Palestinians sent Goliath down as a soldier to fight one soldier from the Israeli side, so that there would be less bloodshed, but we would accept both armies would accept the outcome of that battle between just two men. This happened quite often in historical battles. So the Palestinians sent down Goliath into the valley. Goliath was a very large man, almost 7 feet tall, as he's described. He was covered in armor. He was also carrying a spear and a shield, and he was additionally led down into the battlefield, onto the battlefield by a servant. And that's assumed that the reason that occurred was because he had trouble hearing, and some people have speculated that he actually had a disability that caused continuous growth. At least this is what's argued in Malcolm Gladwell's book. And the Israelites had no warrior to match Goliath, or at least they did not think so. And King Saul was not sure what to do, and David rushed forward to King Saul, saying that he could battle the giant. Now, David had no armor. The only weapon he had was a slingshot. Saul was reluctant, but he had no one else that he could send into this battle. And after all, David was claiming that he could handle this and do this. So he agreed to send David into battle, and David ran down the hill. And as soon as he came into the valley, even though we think in modern times that he was at a disadvantage, everyone there watching that battle that day knew that he had an advantage because he was a slinger with the slingshot. And during ancient warfare, it was typical that cavalry would overcome would overcome slingers, which were people with archers or slingshots. that infantry would overcome, cavalry would overcome infantry and slingers, and a slinger could overcome infantry because they could attack from a distance. And that's exactly what David did. He hurled his slingshot and threw the smooth rock, straight at Goliath, and it struck in his forehead, and then he rushed upon him and killed him. It was so common for soldiers to be killed by slingers in ancient times that the Romans actually had a tool that was designed to pull rocks out of wounded soldiers. But the reason I'm telling this story is because Saul only saw David's weaknesses. He saw a small young man that wasn't fitted for combat, and he was hesitant to send him against this giant. And the giant was the one at the disadvantage because of the setting. And we have to start seeing the competence and the strengths of the folks we support with regard to living independently for supported living, or living with support rather, with supported living, so that we do not limit the options available to them. Like the best option or the best example I can think of is that folks often quickly say that, well, this person can't live on their own because what would they do in case of a fire? That's one thing you hear, if the person has mobility issues or they don't know exactly how to transition. In the work that we have done with the Supported Living Initiative, some of our providers have encountered some questions about health versus safety and risk versus liability. And one example that they've shared with us is about Barbara. Barbara's a 62-year-old woman that there's some real risk with her living on her own. She has diabetes and is aging. She has been living on her own for almost a year now, and she was initially very paranoid of technology that was installed in her home to manage her health and safety. She actually dismantled some of the technology, and it was a real learning experience working with her so that she understood that by having this technology in your home, it allows us to leave you alone more like you like. And the agency felt that her being in her own home was the right risk because she desired it so much, and the liabilities attached to this was something that you couldn't predict. And as the director of Liberty Corner says, liability is the reason we have insurance. There's going to be things that happen that we can't control, but we have to allow the person the dignity of risk so that they can do the things that they want to. Another story about health versus safety is about a lady named Mary that moved into her own apartment. Mary got to know some of her neighbors and went and visited with one of her neighbors, and she wanted to have a beer, and her neighbor had a beer with her. And there was no real issue with this until Mary went one day into her neighbor's apartment and drank beer without her. Mary drank too much beer and actually fell and scraped her face. Well, this was both a health and safety issue and a risk and liability issue, but it's also a life issue. Like, Mary's of legal age, and she has that choice to make. And what the providers had to do is step in and provide education around, first, you can't go into your neighbor's home when your neighbor's not present, because that's breaking laws and other pieces. And also, drinking in excess is something that you can't do if you want to live safely. So the provider took this as an educational opportunity. Mary knows not to go into the home without the neighbor being present, and Mary also has been educated about what's a safe amount for her to drink, as has her neighbor. And Mary enjoys the socialization of having one beer with her neighbor, and she's doing this occasionally throughout the week. But she's having the opportunity to build social connections and to experience some risk and choice. And it hasn't been an issue since she learned the social norms around this, something that she had never experienced prior to that. Okay. That's a couple of examples of health versus safety. We're going to transfer over to Derek, who should be available now for his part of the presentation. Are you with us, Derek?
I am. I've been listening intently, Jesse. Thanks so much. Hi, everybody. I'm absolutely delighted to be on this webinar and have been listening very intently. And when Jesse and Kelly and I talked about this, one of the things we were absolutely committed to, and having been part of webinars where this was not the case, we really are committed to allowing some time for you all to send your questions to us, because we really would like to encourage, as much as you can with 148 people on the line, some sort of dialogue. So I was thinking as Jesse was talking, as somebody that's kind of a frustrated storyteller, about something that happened to me in the mid-'80s in Wisconsin when I was running a program. I was an exec of a very large statewide program based in Madison, Wisconsin. I was sitting in my office one day, minding my own business, when I got a call from a postmaster on behalf of an employee of the Postal Service that was sitting in his office in a very small town up in outside of Stevens Point, Wisconsin. And essentially, they patched the person through to me and said, they said who they were, and I, introduced myself and said who I was. And the postmaster said, well, Jim here has something that he wants to say to you. So Jim gets on, who I've never met, have no idea who he is, and he comes on and says, well, listen, I don't know who you are or what kind of program you run, but he said, I want to let you know that Bob and Jimmy live in this apartment that I deliver mail to every day. Because they have those, boxes, and it turns out the boxes for the delivery are right outside their door, and they come out and greet them every day. So he said, last week I was there delivering these guys mail, and the door was open. And I'm telling you, there was somebody inside that was yelling at these guys. And if they had done that to me, if they were younger, they'd have their mouth washed out with soap. If they were older, they'd be grounded for a month. And he said, you better get this fixed before I do something. I share that story with you because of all the discussions that I've been in about liability and safety, health and risk, and all the rest. I have, for a long time, suffered under the notion that if you have more rules, more regulations, and more inspectors, that people are safer. I am not here to say or to advocate for doing away with them. I'm not on a campaign to try to cut the size of government. I am here to say something that I think we all know, and it really is that people really keep people safe. And in my mind, why people have not been safe in the past has largely been because we've had to rely on the system rather than the natural relationships, or I won't even say natural, I'll say intentional relationships that can be built if we really look at it in the community. And so I said this in a presentation last week at Pinehurst. I think that we have often mixed up the words risk with liability. And as I said last week, you can answer liability, or health and safety to every single question. So in terms of supported living, the first thing that I wanted to say is that we really need to stop and take a look and make sure that we're not coming up with another quote-unquote program that is just an overlay. And in order to make it work, and Kelly, if you're on the first slide, we really do need to change not only our organizational philosophy, our organizational mission, and all of that. I really think we need to change our organizational practice. And it changes the fundamental role of support. And I'm going to just mention some, first of all, very simple-minded, since that's what I am, descriptors that I think you can kind of do a checklist to say, is this supported living or sort of supported living? One of the first things is does the person have the ability to be in a single room and in that room say that you can't come into my room without my permission? And it is truly that they almost like are owning or renting that room. Number two, does the person have a key to the house? And is it their key? And do they have the ability to be able to control that key? And the third thing, and I don't think that this is something that can happen in every single case, but I really do believe if people aren't doing it right now, I think it's good outside of supported living even, but I really think that we need to really insist that the people who are participating in supported living with their own waiver, since the waiver is attached to them and not the agency, that they get to interview the staff. Now, having said all this, folks, I want to share with you at the very beginning, before I get into some of these other things, supported living is a mess. The community is a messy place, and if you truly implement supported living, it is a mess. A couple of weeks ago, when we got together to do our planning for next year, Lars, who works with FIRST, who is supporting a very challenging, an individual with challenging behaviors. The individual isn't challenging, her behaviors can be somewhat challenging, talked to me about the challenges that they have faced. And when I knew it before, but when I really knew he got supported living, is when he said that she had run away. And rather than starting into the whole treatment modality of that was inappropriate, you know, what are we going to do? All he wanted to know from her was whether or not she was safe. He just kept saying, are you safe? Are you safe? Are you safe? And then second thing he wanted to know is there anything I can do? It's those moments when we're tested that I think we find out whether or not we really understand supported living. Supported living raises all kinds of issues about liability because we have people making choices about things that they may not have been exposed to. And the question sometimes is that the liability that a provider feels may fly absolutely in the face of somebody's individual choice and decision making. I think this is going to take an awful lot more debate and discussion. I just wanted to let you know that I acknowledge, as a former provider and now a consultant, how messy supported living can be. The other thing about risk is if somebody wants to do something and there's not enough staff, the risk of having them do it on their own may outweigh the idea of letting them do it and having to take everybody else with them. But the first thing is that we have to change the nature of the relationships and the flexibility of the support. And I know that we're struggling to find staff anyway. An awful lot of agencies that I know that are doing supported living are having some very non-traditional staff, including next-door neighbors, including people at their church. And I understand all the issues about vetting and all the rest, and I'm not unmindful of that. But I'm seeing an awful lot of different people hired and an awful lot more part-time individuals, which raises a whole other issue, I understand, about benefits, salary, and pay. I'm just saying what I'm seeing in terms of that. The next piece is the edifice complex. The edifice complex is essentially where we think that we still can have buildings that are controlled by us and have supported living. The first definition of supported living I was ever involved in was in 1988 in the state of Ohio. And Ohio wrote into statute, not rule, not regulation, but wrote into statute that one of the things is that the provider owned the building, they couldn't run the services. Now, North Carolina has actually had a separation for a very long time of an awful lot of housing. The question is whether or not people are having, according to HCBS, the new waiver standards and some other things, are we moving towards where people are having individual leases so that I control the property? This is an absolute mess, and I've been part of this too, Could somebody change their provider and stay in their current home? Could I decide that I really like where I live, but frankly, I would choose a different provider? Raises all kinds of issues that we haven't settled, but ones we need to really need to address to make sure that we get over the Oedipus complex. So in addition to there being shared authority, which is really what we're moving towards, there's also shared risk. And that shared risk is something that sometimes raises all kinds of challenges to families, to providers, to systems, even to advocates at times. But by creating a culture of respect and empowerment and really trying to facilitate people not only speaking for themselves, but acting as if they are in charge, it really changes the dynamic of the situation. Next slide, please, Kelly. And so we have to make these innovations functional. And I know of some agencies outside of North Carolina that have been planning for supported living for going on 5 years. And they keep running into obstacles. That the rate isn't exactly right for everybody they want to support. They're starting too big. And as a result, we have to change the dynamics. I've said this for a very long time. When people say, well, I don't really know what to do, the best way to learn is to start. And it isn't that we're going to jeopardize people's safety by learning on the fly. But we can start small, which minimizes risk. And I tell people all the time, and it gets to Jesse's 17%. If you start with 1, you can get to 2. If you can get to 2, you can get to 200. If you can get to 200, you can get to 2,200. But if you don't get to 1, if an agency is not even supporting 1 person in supported living, I think it's going to be very difficult to get to even 2 within the agency, which means we really have to customize the services and supports and build on the principles of self-determination and self-direction. And I'm getting way ahead of myself. The next iteration of supported living that some states have moved towards is actually having people have some control over a portion of their budget. Because if you really want to find out what people want, if they get to not only direct the services and say what services they want, but if they get to control a portion of the budget, I don't know about you, if I go to a restaurant and I get bad service, I don't have to write them a letter, ask them to do an IEP, an ISP, or one of those P things. What happens is I don't go back. But the money is in my control. Now, I know that there's the argument of public money, who controls the money, but we have to start having these discussions at the same time that we're dealing with these issues of risk. The final thing on this slide is I think we have to redefine quality. And Michael Small gave us this template 40 years ago, which I also mentioned last week. And the template is that true quality can only be measured by not that which is important for somebody. The for somebody is the rules, the regulations, the things we need to have in place to ensure people's quote-unquote health and safety. But true quality is really only defined by the person in terms of the things that are important to them. I think about it last week in terms of going to the very wonderful, wonderful buffet that I was able to participate in down at the Pinehurst Conference. And it was a smorgasbord of a breakfast, and it was absolutely overwhelming, and there was almost too many choices. But I decided that if I only had one life to live, that I was defining quality as things that either had grease or had sugar. So I didn't spend an awful lot of time at some of what other people might have called the healthy alternatives. But that was quality to me. So each individual can really tell us about quality. And this next section that talks about satisfaction, there have been some looks at some alternative support models when individuals are more control of their lives, when there is shared authority, shared risk. And the outcomes are quite striking. And first of all, while families may be or guardians may be very, very resistive initially to people living in an apartment. And we're not talking about quote-unquote independent living. We're talking about supported living. So people may have an awful lot of in-depth supports, but some people may not have supports overnight in the same way that they did before. We talk about those supports. Once families have experienced them on behalf of their loved one, the overall outcome and satisfaction for most people, and I want to underline most people, tends to be very, very high. The second thing is that we've seen improvement significantly on baselines on previous results about skill levels, about retention of learning, just all kinds of things that people have not been able to do before. Well, all of a sudden they're doing them, and somebody said, well, you're not supposed to be able to do that. Well, they never had the opportunity. We also are seeing increase in connectedness and relationships. In many cases, behavioral challenges go down because we've tried to minimize power struggles. We're putting higher personal responsibility on somebody. I have a friend that experiences a disability that wanted to have control of his money, and he blows his money. And it took him a couple of weeks of, rather than taking $40 a month and getting it all at once and having it be gone in 4 or 5 days, it didn't take too many times, where now he has asked the staff to please give him $10 a week. That has built some incredible personal responsibility on his part and also has led to some higher skills. The last thing I'll say about this slide is that we have to really ask ourselves a hard question, and that is, how many people have at least one person in their life that cares about them, that's not paid to be with them, not another family member, and not another person with a disability. And the residential services that I grew up in, with all the best of intentions, that were more, I started in an institution, but forget about that. I worked in an ICF, forget about that. Let's talk about group homes. Group homes, in many cases, don't, and it's not intentional, but they don't promote and have a hard time promoting individual and shared responsibility, because so many things are done for somebody in that setting. All right, the last slide, Kelly, is that the outcomes that we really want for people is that people are not just in the community but are of it. People aren't just present but they participate. People are not just clients but are exercising their rights and obligations of citizenship, and they really belong. And there's a difference between connectedness and belonging. It's the connectedness that people feel when they're part of a singing group. It's the connectedness people feel when they are in church with people that they know. It's a connectedness, a belonging that someone feels when they have a deep relationship with at least one other person. The second thing that happens is that people have a variety of relationships. And those relationships are sometimes casual because of work or because of play or places they go. But we need to start measuring community not as the place where people go, but the people know. And if we started looking at community that way, I think we'd find that there's an awful lot of people, as I said, that are in the community but not of it. But if people have a variety of personal relationships, then some of those relationships inevitably, in most cases, I'm not going to say all, in most cases, will lead to valued roles in the community. So it isn't just volunteering when it is volunteer group, all with people with disabilities, which is a very valuable thing, and please don't think I'm putting that down. But it's asking somebody to be part of a shift at a Christmas tree lot at church that's part of the regular lot. There's a young woman with Down syndrome that plays on an opposing team in soccer and basketball with my now 8-year-old granddaughter, and she's been on this team for 3 years. That sends more of a message than all the public service announcements and all the spots that I've ever seen. She is there, is a part of this team. She plays the same amount as the other girls on the team, and she has a valued role in the team. And finally, I wanted to finish with connecting with your past. This individual who is a friend recently lost his brother-in-law. And I will be the first to admit that I underestimated Andre's grief at losing a brother-in-law that he did not see very often. And he reverted to some of his past behaviors that we had not seen in quite a while. And I am embarrassed to say, after knowing him for almost 20 years, that I didn't give enough credit to the fact that Thurman, his brother-in-law, had taken Andre an awful lot of places when Andre was younger. and I'd forgotten how warmly Andre talked about Thurman. And that connection to the past has left an indelible mark on him, and I can only imagine the loss that he's feeling. So it doesn't have to do with how often you see somebody, but I think it's important when people transition. I think about this to people that I've helped transition out of institutional settings. Do we make arrangements for them? And I understand sometimes people don't want to go back because they're afraid they're going to be readmitted. But I think we really do have to be sensitive to working on relationships and the opportunities for people to continue to connect with people with whom they have had long-standing relationships. With that, Kelly, I'm going to stop and turn it back to you.
Great. Thank you both, Jesse and Derek. Okay, so now's the time that we're going to do questions and answers. In the GoToWebinar screen, you will see an area where you can either chat or ask questions. So feel free, if you have something that you would like one of the presenters to answer, to type your question there. The first question we have is from Melissa Hint, and she said, this is why personal experience outcome interviewing is so important with a member. Do either of you guys want to, that was really a comment, but do either of you guys want to just elaborate on the personal experience outcome interviewing and why that's important to individuals with IDD as they transition into supported living?
Jesse, you want to take the lead on that?
Yes, please do so, Derek.
Oh, you're tossing it back to me. I assume that you're talking about the personal outcomes initiatives. Is that? I hope that that's the nature of the question. I think. Well, I'm sorry if I misunderstood the question because I can't see my my screen to go back to my notes. I really think we have to follow up with people individually and find out what are the personal outcomes that they want for themselves. And a lot of times people say, well, we do person-centered planning. Well, I remember an old colleague of mine, Mike McCarthy, who has now since passed, and he lobbied for a very long time that we need to stop talking about person-centered planning and need to start talking about person-centered work. And so the work of this is trying to meet with individuals and talk about not just the dreams that they have, but the outcomes that they want in their life, and have an interview that is functional to them. I could talk all day long about the fact that a majority of the people with whom I work don't read. And if we're using any kind of tools for questions that are simply words, we're missing most of the people, at least with whom I work. I think we need an awful lot more of alternative sensory kind of materials, which includes pictures and sounds and devices that people can manipulate and real objects that people can look at and touch and feel to be able to tell us about the things they want in their life. I apologize if I missed the gist of the question, but I think those personal outcome interviews are incredibly important as we're not only doing planning, but constantly revisiting it, because it isn't a static thing. I don't know about you, but I once thought that I really wanted to play touch football after, as an adult. And I found out that it was a hell of a lot more running than I ever thought it was going to be. I needed to experience it, but I'm glad somebody didn't have me have to do it once a week for 2 years or a year for another plan to come up. I simply said I wasn't interested in continuing to play. So it isn't just the initial decision, it's the revisiting of the decision. Jesse, I don't know if you want to follow up at all on that.
I think you captured the comment really well, Derek. I would also add that one thing that we do in our state is we require providers to receive an accreditation to provide services. And many of the accreditations that we accept are accreditations that are tied to facility living and measurements of facilities instead of true person-centered type outcomes. And I would agree that the personal interviews and really understanding what the person wants out of their life is an important part that we sometimes miss, even in our person-centered planning process. And that's something that we have to strive to improve for sure.
Great. Okay, next question is from Selena Jackson. And Selena, I'm going to unmute you. So you should be able to ask your question now.
Oh, one of the questions that I was wondering about, some patients who are deaf and who have voice or would like to be more independent, but most of them have guardians who are against them being independent. So what do we do in cases like that?
Jesse, I know you're much closer to that in North Carolina than I am.
Well, the first step is knowing exactly the authority that a guardian has with regard to the individual's life. Because often guardians overstep their bounds and go well beyond the items that are outlined in state statute about the responsibilities of a guardian. One good resource that addresses the responsibilities of a guardian is located on the Disability Rights North Carolina website that talks about the responsibilities of a guardian. Sometimes approaching the guardian with that document is the best way to move forward. Also, introducing the guardian to an initiative that the North Carolina Council on Developmental Disabilities is sponsoring, in addition to this one, about redefining guardianship or rethinking guardianship. And Linda Kendall Fields is a resource that you could refer the person to learn more about what the guardian's actual roles are. So it's really more, in my opinion, about first trying to educate the guardian, because we often do run into difficulties with guardians because guardians think they have a lot more risk and liability than they actually do. So I think that's the first starting point, and I can't think of another. Is there anything you'd like to add, Derek?
No, other than I get this question all the time. And as a former sibling, my brother has now passed, but as a former sibling, my father literally thought that everybody was capable of supported living. Supported employment except my brother. And my father and I talked about this for 20 years. So I do not want to underestimate when a guardian says no, what a provider is up against. My only, I have 2 points. Number one, if you can do it, families or guardians talking to families is much better than providers talking to families. And secondly, I believe that talking begets talking. And I have literally, the longest I've ever worked with a family, and it wasn't successful, was 7 years. But they kept talking the whole 7 years. They were the guardian. They had the ultimate decision-making. I think it's important to keep the channels of communication open, but it's an incredible, difficult position for a provider to be in, and I don't want to minimize it if a guardian says they're not going to have the person be in a more independent or a supportive setting.
Thank you so much for your question, Selena. Did that answer it?
Yes. Thank you so much.
Oh, wonderful. Is there anybody else who has a question they'd like to ask the presenters? You can either add the question in the thing, you can raise your hand electronically and I can unmute you, or you can input the question in the chat. Okay, here is a question that was inputted in the question section. How do we train group home staff to think and act differently to support individuals in a supported living environment? So how do we train group home staff to think and act differently and support individuals in a supported living environment?
I'll take a stab at that and then allow Derek an opportunity to say a few things too. One thing that we're doing in our area is we're encouraging the use of a training curriculum for staff called Supporting Informed Decision Making. It's a product that's offered by the North the National Association of Direct Support Professionals. And there are certain parts of that that we can share as examples for staff. But it's really about helping the staff understand that they are a support. Staff often get caught up in the idea that they're there to keep the person safe, make sure the person goes through their daily routine, help the person do activities. They'll set boundaries sometimes before the person can do other activities. And if you really think about it, nobody's life works that way when they're out of services or not receiving supports from others. So the support staff's real job is to evaluate each decision that the person makes with the person to help them understand which choice they should make or which choice might be the best choice. What are the consequences of the choice that you make? So those are the pieces that the informed decision-making curriculum breaks down for the training of staff. And we'll be sharing more details about that, and it's likely we will do a webinar that goes into the specifics about informed decision-making with some folks from the National Association of Direct Support Professionals, because they really break it into a 5-step process that focuses on hearing the individual and what they have to say. And they offer a number of videos that show people interacting with people with different communication skills. Because when you're helping a person that is nonverbal to communicate, when you're communicating with a person that is nonverbal and trying to make sure they understand the choice that they're making, it's very different than when you're doing it with someone that is verbal. So I think that will be a wonderful topic for a future webinar. But it's a type of training that we must focus on with direct support professionals where they understand that they're there to help the person make choices, not make choices for the person. Eric, would you like to
Thank you so much.
Do you want to go on to another question? Because there's another question. I'm fine with either, Kelly, if you want me to comment or just move on. I'm okay with either. I thought Jesse did a great job on that question.
I think Jesse did a fantastic job. Let's go to our next question because we are running out of time. So the next question is, how do we know that a person is ready for supported living?
I think that's one for you, Derek.
Yeah, okay. First of all, it's a great question. And secondly, the question, and I thank the questioner very much for the courage of asking it, belies the whole challenge of supported living. There is no entrance or exit criteria for supported living. The only requirement is that the individual desires it, that obviously if they have a family or guardian, that they would approve it, and then finally from the provider's perspective, I get that there has to be a rate and sufficient staff to support it. I grew up in a system that was built on a series of boxes and buildings where you graduated from one to the other, and the exit criteria to group homes was the entrance criteria to semi-independent living. The exit criteria to semi-independent living was the entrance criteria to independent living. So there is no readiness criteria for supported living. That does not say that people are not going to need supports. And what I'm so glad the question got asked, because what may be in some people's minds is, wait a minute, I serve people or support people that have really significant and challenging needs, and I can't picture them living, quote unquote, in an apartment by themselves. I have worked personally with individuals that have come directly out of institutions and have gone into apartments. However, those apartments were staffed with not only day staff, but staff that stayed overnight. And it's a long story, but in some cases, they literally slept on somebody's couch for a while. In some cases, people may need lifelong overnight support. So everything from somebody that needs drop-in support to somebody that needs almost total care falls under the rubric of supported living. I am not saying that the state of North Carolina is funding it or not funding it in terms of your rate structure. I'm not talking about the bureaucracy side of it. But in terms of the person side of it, there is no entrance criteria for supported living. And again, thank you for the question, because I think it's something that is very important at the beginning of an initiative rather than at the end.
Fantastic. Okay, we have another question that has been asked. How do we treat confidentiality the same for the individual we support with their neighbors, etc.? If we are intervening on the person's behalf in the way Jesse mentioned about providing education. So how do we treat confidentiality with regards to the natural supports that would be surrounding the individual in supported living?
Well, that has to be with informed consent. When you're putting together a plan for a person to live in the community, one of the things that you want to do is foster connections with folks. Derek talked about the need for connections and how we really can evaluate the quality of a person's life by the number of connections that they have, how many real friends they have, those kind of things. Sometimes you need to make sure with the person, you're working with or their support structure that it's okay to share specific information with their neighbors. Sometimes it's not. With regard to Mary, it was appropriate to share with her neighbors because they actually went around and visited the neighbors when she moved in, so that she got to know a few people, and the person that she had the beer with invited her in. So when that issue happened where she went into her house and drank more of her beer when she was not there, that right there is an issue that for most people could lead to some type of criminal prosecution. Fortunately, this person didn't feel that way because she had already met Mary and she knew that Mary had that Mary was different in some ways. So it's one of those really, it can be sticky if you adhere to the rules too ardently, but at the same time you don't want to violate the person's right to confidentiality. Sometimes we lose sight of what makes sense because of our willingness or desire to adhere to the rules, when what we're supposed to do is ensure that the rules are supporting the person. So in Mary's case, it was essential that some of her neighbors knew certain things, and Mary was willing for her neighbors to know those things. So that is a piece that has to be there. It's that informed decision-making that's required, not just about living on your own, but about what you want this person that you want a connection with to know about you. Those kind of pieces. It's not going to be the same for every person, and it will be different. I mean, I think Oscar Wilde really captures it best when he says the truth is rarely pure and it's never simple. Well, what we're doing is never pure, and it's rarely simple too. So that's the best answer I can offer.
Wonderful. Well, and that's going to wrap it up for our Lunch and Learn webinar. We appreciate everyone who joined us to take an hour out of their busy days to learn more about supported living. We will be announcing the date for our next webinar by the end of the year, so keep your eyes on your inbox, and we will be sending that information out. If you have any questions, feel free to email Jesse after the presentation or myself, Kelly, at cb-cg.com. Thank you all for joining. Have a fantastic day.
Thanks.
Thanks.